Assalamu alaikum wa rahmatullah. How are you, everybody? I'd like to, first of all, to welcome Professor Atul from Canada. Professor Atul Verma is the head of the Heart Rhythm Program at South Lake Regional Health Center. He has over 170 peer-reviewed publications in the New England Journal of Medicine. He has served as a co-chair for the Canadian Cardiovascular Society Atrial Fibrillation Guidelines Committee. We are welcoming him with us. I'd like to welcome everybody, thanking Bayer Company for this event. I would love if we can all get benefit from the two lectures, myself, Dr. Sam Mansour, and Dr. Atul Verma, who will start his topic about diabetes, renal failure, atrial fibrillation. Dr. Atul will cover all the aspects of the importance of NOACs in this topic. Welcome, Dr. Atul.
Thank you very much, Dr. Hassam. It's a pleasure joining you. I want to thank you and your colleagues for hosting me in this virtual event. And I also want to thank Bayer for supporting this event. It's my pleasure to be joining you. It's an honor. So today I'm going to be talking to you a little bit about the challenges of oral anticoagulation with a specification in the diabetic and renal failure populations. And these are my disclosures for your information. And I also want to make a disclaimer in front of my presentation that some of the discussions that I'm going to be having with you today represent off-label indications for oral anticoagulation. And although this disclaimer is specific for Canada, and I have to provide this for my Canadian colleagues, I also extend this to my Bayer colleagues in Egypt. So I think we all by now, after 10 years of having NOACs, are pretty convinced that NOACs are for non-valvular atrial fibrillation the preferred therapy for oral anticoagulation compared to vitamin K antagonists. And that's because they have a very excellent safety profile. They reduce fatal bleeding, intracranial bleeding. There's a trend towards reduced mortality. And they also have excellent adherence because there's no need for additional monitoring. Speaking of adherence, we also know that once daily medications are often taken more consistently by patients compared to twice daily medications. And so in my own personal practice, I tend to choose once daily medications more often than not. I think you can see from this data from my colleague Jason Andrade that clearly the once daily therapies have better adherence. So I'm going to talk a little bit about elderly patients because elderly patients represent a very challenging population. These are patients in whom we cannot always provide, or we think we cannot always provide oral anticoagulation because they're too frail or too high at risk of bleeding. But in fact, we must remember that there were actually quite a large percentage of elderly patients included in the pivotal trials, and we forget that. For example, in Rocket AF, more than 40% of the patients enrolled in the trial were over the age of 75. So this represents real patients that we would see in the real world. And if we look at how these NOACs perform versus vitamin K antagonists, even in the very elderly population over the age of 75, we see across the board that the risk of thromboembolism is either equivalent to or better with the NOACs compared to vitamin K antagonists. And if we look at the risk of major bleeding, we can see again that all of the NOACs are associated with either equivalent or reduced major bleeding in the elderly population compared to vitamin K antagonists, with one exception, dabigatran 150 milligrams. Dabigatran 150 milligrams BID is actually associated with a higher risk of bleeding in elderly patients and therefore should generally be avoided in that patient population. In terms of fatal bleeding, I think it's important to remember that fatal bleeds are also reduced in the very elderly population to the same degree by NOACs as they are in the rest of the population who are not elderly. And this is some data from the recently presented SAPHIR AC prospective study. And this was basically a prospective study that was carried out in very elderly patients. The mean age of these patients was 86 years, and they had a CHA2DS2-VASc score of 4.6, so very high-risk patients, and also a relatively high HAS-BLED score of 2. And they enrolled more than 1,900 patients one-to-one to either rivaroxaban or VKA, and you can see that even in these very elderly patients, the risk of major bleeding, intracranial hemorrhage were statistically significantly better with rivaroxaban compared to VKA, and even mortality was almost significantly reduced by rivaroxaban. So I think it's very important to remember that NOACs have a very good safety profile, even in the very elderly patient population. And bleeds should not necessarily make you fear oral anticoagulation, and I'll tell you why. Because many of the bleeding risks are actually modifiable. And if we modify those bleeding risks, we can reduce the risk of major bleeding even in our very elderly patient population. So, for example, some of the biggest risk factors for bleeding are concomitant NSAIDs or alcohol and uncontrolled hypertension. And these are things that we can talk about our patients with. We can control hypertension better. We can take NSAIDs off of patient regimens while they're on oral anticoagulation, and we can counsel our patients to consume less alcohol. And if you modify these modifiable risk factors, you can see you can substantially reduce the risk of bleeding by more than twofold, according to this data from the Xanthus prospective registry. I also want to talk about another very important issue in elderly patients, and that is our tendency to provide them with a low dose of anticoagulation, even though they may not meet the criteria for dose reduction. And the reason why that is important is because when we reduce the dose of NOAC inappropriately, we are also increasing the risk of stroke. But you might say, well, yes, okay, I accept that, but at least I'm protecting against bleeds. But in fact, we may not be protecting against bleeds as much as we think. And I want you to look at this data, and I want you to pay attention in particular to the data at the top with apixaban, because we often see apixaban being given in elderly patients, and we often see it being dose reduced inappropriately in elderly patients. And you can see that the risk of stroke and systemic embolism goes up by nearly 2.5 times if you underdose apixaban. And yet, when you look at the risk of major bleeding, it's almost exactly the same. So, in other words, it's like we're saying to our patient here, please take a pill that will not protect you against stroke, but will still increase your risk of bleeding. And when you put it that way, I'm sure many of our patients would not want to take such a pill. So appropriate dosing is very, very important for our patients. So I'm going to turn gears here, and instead of talking about elderly patients, I'm going to talk about diabetic patients. And I think we should understand or remember that diabetes is actually a risk factor for developing atrial fibrillation. So many of us know that hypertension and sleep apnea are risk factors for AFib, but many of us did not realize that diabetes is also a risk factor for atrial fibrillation. And in fact, there is a lot of sources of data from the Framingham Heart Study, as well as other large prospective studies, which show that diabetes is associated with a 40% increase in the risk of atrial fibrillation. And this is some data that was published not too long ago in Lancet Diabetes. And you can see here at the top that the risk of atrial fibrillation goes up as your hemoglobin A1C increases. And you can see that if patients also have evidence of micro or macroalbuminuria in their urine, that further increases the risk of developing atrial fibrillation. In fact, even impaired fasting glucose can increase your risk of developing atrial fibrillation. And here you can see that this analysis was corrected for BMI, because we know that BMI is also a risk factor for developing AFib. And even when you correct for BMI, fasting blood glucose impairment is still a risk factor for developing AFib. The other reason why the interaction between diabetes and AFib is important is because there is a lot of data that suggests that AF outcomes are worse in diabetics compared to non-diabetics. Now, there are lots of possible mechanisms for this. We know, for example, that diabetes has a multiplicative effect on adverse outcomes with renal disease, vascular disease, etc. There's increased thrombotic activation in diabetics. There's dysautonomia in diabetics. So there may be multiple mechanisms by which the outcomes are worse. But if I show you this data from the Orbit AF registry, what you'll see is that if you take AF patients who do not have diabetes and you compare them to age-matched patients who do have diabetes, the difference is striking. The diabetics have significantly more mortality compared to the non-diabetics. Now, if we look at were diabetics studied in the prospective randomized trials of NOACs, the answer is yes. There was a high percentage of diabetics included. And in fact, the Rocket AF study had the absolute highest percentage of diabetics along with the ENGAGE study. 40% of the patients enrolled in the trial were diabetics. And if we look at the outcomes in Rocket AF in the diabetic population, we see that the outcomes were either just as good, if not better, in the diabetic population compared to the non-diabetic population when you compare rivaroxaban versus warfarin. This is a meta-analysis of the 4 different NOAC trials in the diabetics. So the top forest plots represent the diabetic population, and the bottom forest plots represent the non-diabetic population. And what you'll see very instantly is that the risk reduction in stroke and systemic embolism in the NOAC group was better than the risk reduction in the warfarin group, both in the diabetic as well as in the non-diabetic population. And when you look at bleeding, again, you'll see that bleeding outcomes were better in the NOAC population, even in the diabetics, compared to the non-diabetic population. Another very important outcome that we are just learning to deal with is major adverse limb events. So most of us are used to hearing about MACE events, major adverse cardiac events, but many of us are less familiar with the term MALE events, which are major adverse limb events. And this includes things like amputation. And think about it. how much does a patient fear amputation? And for diabetics, they actually fear losing a limb almost as much as blindness or death. And yet, when we compare major adverse limb events in the rivaroxaban group compared to the warfarin group, what we see is that rivaroxaban statistically significantly reduces the risk of major adverse limb events, including amputation, compared to warfarin. So this is another great reason to use NOACs in your vascular disease diabetic patients. These are just pooled event rates comparing the outcomes in diabetics versus non-diabetics. It basically shows that the outcomes overall in diabetics are a little bit worse because obviously I just finished telling you that diabetic patients have higher risks of stroke, mortality, etc. But if you look at the reduction in diabetics versus non-diabetics in outcomes like stroke and systemic embolism, and in terms of major bleeding, the NOACs generally show a benefit. So this is some data of apixaban patients with non-valvular atrial fibrillation and diabetes. And what's interesting to see is that certainly on the stroke and systemic embolism side of things, there is a significant reduction in stroke and systemic embolism in the diabetic and non-diabetic populations. The bleeding is not so straightforward, so it's kind of interesting that in the diabetic subgroup of patients, apixaban did not show a statistically significant reduction in bleeding events, but it did show it in non-diabetics and other patients overall. Management of atrial fibrillation doesn't just mean management of the rhythm itself. It means management of the whole patient. And we know that to be true, especially in our diabetic patients. Our diabetic patients have obesity. They have vascular disease. They have coronary disease. They may have sleep apnea. They may have heart failure. And so if we really want to fully treat our diabetic patient, it involves treating the whole range of things that are associated with diabetes. I want to talk a little bit about obesity because obviously there's an important interrelationship between diabetes and obesity. And I often get asked by a lot of people, do you feel comfortable using NOACs even in your very obese patients? So, for example, if the BMI is more than 35 or 40, how comfortable do I feel about using a single dose, once daily drug, even in my very obese patients? And the answer is, if you look at the total number of patients enrolled in the various trials with a BMI greater than 40, there were actually lots of patients enrolled, and therefore we can look at some of these outcomes. Now, one of the important things I want to remind you is that when you're calculating creatinine clearance to determine the appropriate dose of your NOAC, it's very important that you use the Korotkov-Gault equation, because the Korotkov-Gault takes into account the age and, importantly, the body weight, in addition to the sex and the serum creatinine. So if we look at patient 1, for example, where they are male, age of 80, and their weight is 85 kilograms and their creatinine is 1.1, their creatinine clearance is 64. But if we take a look at exactly the same patient, but now we increase their weight to 130 kilos, their creatinine clearance now calculates to be 98 mils per minute. And what's reassuring is that if we look at the pharmacokinetic modeling of rivaroxaban in patients who are at the extremes of body weight, what we see is that the concentration curves, even in the very obese population, are very, very similar to the concentration curves even in the less obese population. And so if we compare the real world evidence available in obese patients with rivaroxaban, and in this case, this data comes from the venous thromboembolism population. So this is not an atrial fibrillation population, but a VTE population. What we see is that if we look at the risk of recurrent venous thromboembolism, it's pretty much the same across the board, even in the very obese patient population. There is a statistically significant reduction in the risk of VTE, even with rivaroxaban in very obese patients. And if we look at major bleeding, we see that the major bleeding rates really do not change according to body weight. And if we look at, what some experts are saying about the availability of data on NOAC use in very obese patients, we see that in some expert summaries, there is in fact an increased confidence level in both apixaban and rivaroxaban in the very obese populations because more of these patients were studied in those trials. Now, one of the biggest comorbidities of diabetic patients is obviously renal failure. And I think it's very important to understand the interaction of NOACs in the renal failure population. And one of the things, I'm going to show you some data here from the Rocket AF study. And these gray bars represent patients with stable renal function. And in a moment, I'm going to show you some pink bars, which represent patients with actively declining renal function. Now, if you had your guess, I think most people would say rivaroxaban would probably do better in the stable renal patients compared to the patients with worsening renal failure. But in fact, when you look at those patients, the patients with worsening renal failure actually had better outcomes with rivaroxaban compared to the patients who had stable renal dysfunction. And the question is, why is that the case? Why, if rivaroxaban is cleared in part by the kidney, would patients with worsening renal function do better with rivaroxaban? And the answer is in part related to this. So when we use warfarin in patients who have renal failure, one of the problems is that vitamin K not only inhibits thrombotic factors, but vitamin K also can inhibit factors that prevent renal vascular calcification. So if our patients are taking a vitamin K antagonist, they are not only going to inhibit their thrombotic system, but they're going to inhibit proteins that reduce renal vascular calcification. So when you take warfarin, the risk of renal vascular calcification goes up, and your risk of renal failure, therefore, accelerates. And when we look at this data from the Mayo Clinic group that was published in JACC a couple of years ago now, what we see on the left-hand side are patients with a greater than 30% decline in eGFR, and on the right-hand side, we see a doubling of serum creatinine. And the red curves at the top represent the warfarin patients, whereas the other color curves represent the NOAC patients. And what you'll see is that warfarin is associated with a much higher rate of decline in renal function compared to any of the other NOACs. It's also important to remember that, at least for the 10A inhibitors, there isn't much of a change in drug exposure with any of the 10A inhibitors, even with severe renal dysfunction, compared to patients with normal renal function. And the only drug where there really is a substantial change in exposure is in dabigatran. So dabigatran is really the one drug where worsening renal function can really change the concentrations, but with the 10A inhibitors, you can see with rivaroxaban on the left, there's hardly any change in the drug concentration, even in severe renal impairment. And that's one of the reasons why, for many, many years, Xarelto has been approved for use down to creatinine clearances of 15 mils per minute in the United States, in Europe, and in many other parts of the world. In Canada, the lower limit was always 30 mils per minute, but that has recently changed in Canada now, and Xarelto, you can use it down to 15 mils per minute. So even patients with severe renal failure, you can use Xarelto. And if we look at the United States, for example, and we look at the labeling for apixaban and rivaroxaban, especially in patients who are on dialysis, we see that the FDA labeling is identical for rivaroxaban and apixaban. So in fact, in the United States, many centers are starting to use rivaroxaban even in the dialysis population and not just apixaban. If we look at the outcomes of apixaban versus warfarin in dialysis patients, there has been a lot of data now available in the United States. And what's interesting is that when it comes to intracranial bleeding and death, there didn't seem to be much of a difference between apixaban and warfarin. If we look at rivaroxaban, there is also now a lot of data available on rivaroxaban in dialysis patients in the United States. And you can see in this analysis that even though there were very wide confidence intervals and nothing is statistically significant, you can see overall that the point estimates seem to be lower in dialysis patients with rivaroxaban compared to warfarin, including, importantly, intracranial bleeding and even gastrointestinal bleeding. This is some data from the Valkyrie study. This is a study where they actually randomized patients who were on hemodialysis to either receive warfarin, low-dose rivaroxaban 10 milligrams, and low-dose rivaroxaban 10 milligrams plus vitamin K. And they compared the outcomes at 18 months in these patients. And please keep in mind, as I've indicated on my slide, that this does represent an off-label usage of rivaroxaban. And look at the results. You can see that the two rivaroxaban groups, whether they got vitamin K or not, there was no difference. But clearly the vitamin K group did worse. So even in this small study, we can see that vitamin K antagonists are not very good drugs, even in the hemodialysis population, and maybe we need to start opening our minds to the NOACs even in the dialysis population. There was some recent data published on apixaban in the hemodialysis patient population. It was a small study. They were supposed to enroll 760 patients. They only ended up enrolling 150 patients. This was the renal AF study, which was presented a couple of years ago at the American Heart Association meeting, the American College of Cardiology meeting. And you can see here that when they looked at their primary endpoint of major and clinically relevant non-major bleeding, there was no significant difference between apixaban and warfarin in this patient population. If anything, the apixaban arm seemed to be numerically slightly higher, but I think it's still further data that supports that maybe we may be able to use NOACs even in our diabetic population. So I'm going to start to wrap up here, and then I would be very happy to take any questions from the audience. But I would like to conclude by saying that diabetes is a very important risk factor for developing atrial fibrillation. Furthermore, we know that diabetics with atrial fibrillation have a worse prognosis compared to non-diabetics with atrial fibrillation. Diabetes is a leading cause of renal failure, and NOACs may actually slow down the progression of renal failure. And NOACs can also work very well even in patients with severe renal dysfunction and possibly even hemodialysis. So I'd like to thank you very much. I will stop sharing my screen at this point in time. And at this point in time, I'm very, very happy to answer any questions or talk about any other topics that people may be interested in.
Thank you very much, Dr. Atul Verma, for the really very nice lecture and a lot of new data about NOACs in general. I'd like to raise some questions. So in order to summarize what you said regarding the patient with low creatine kinase below 15 and on dialysis, in your real practice, which kind of NOACs you prefer to use it in such patient? If you're gonna choose one of the new NOACs, which one do you prefer in those patients, rivaroxaban or apixaban? Of course, I'm sure not the bigatran, but what's your choice?
That is correct. So I think in our dialysis hospital, we don't have dialysis at our hospital, but in our sister hospital that has dialysis, we have started using NOACs quite regularly in many patients, and we are choosing either apixaban or rivaroxaban in those patients. I think dabigatran is not a good choice because obviously it's very dependent on renal clearance, so I would not use dabigatran. And right now, edoxaban has only very, very limited data. So I think the two NOACs with the best data in the dialysis population are apixaban and rivaroxaban.
Okay. You have given us some good information about the difference in major bleeding when using the NOACs. What's your way of management if bleeding happens for one of the patients who was under NOACs, whether mild, moderate, or severe bleeding? What's your strategy in those kinds of patients?
Yeah, so Dr. Osam, thanks for that excellent question. So, I think it's, important, and I like the way you classified it as mild, moderate, or severe bleeding, because many people just clump all the bleeding together. So if the patient comes into your office and says, I had a minor hemorrhoidal bleed or I had some minor nose bleeding, there's a tendency for doctors to say, oh, you had a bleed? Okay, I'm going to stop the medication. But in fact, you don't have to do that for mild bleeds. So if you have a mild bleed like bruising on your skin or a mild nosebleed or bleeding while you brush your teeth or hemorrhoidal bleeding, this is only minor bleeding. And so I usually tell my patients, listen, this type of bleeding is not going to cause you to die of bleeding. Your hemoglobin level probably won't even change. And if you compare the nuisance of this small bleeding compared to the risk of stroke, I would just continue the NOAC despite this occurrence of nuisance bleeding. On the other hand, let's say it's moderate bleeding. So let's say they're having some GI bleeding or urinary tract bleeding, and maybe their hemoglobin is actually dropping a little bit, and now you're concerned, so you send the patient for further evaluation. I think, again, here, the most important thing is to find the underlying cause and to treat the underlying cause. So, for example, if the patient has an ulcer that is bleeding, then it's important that the gastroenterologist scope, they find the ulcer, maybe they inject the ulcer, the patient should go on a proton pump inhibitor, and eventually that ulcer will heal. So maybe you can stop the NOAC for a very short period of time while the hemoglobin is dropping. Maybe you stop it for 2-3 days until the ulcer has been injected, and then you can restart the NOAC and put the patient on a proton pump inhibitor. Similarly, if they're having urinary tract bleeding, the urologist can do the cystoscope. They can look, they can find why the patient is having a bleed. Sometimes they may find a bladder tumor and they have to deal with the bladder tumor. Maybe it's prostate cancer, they have to deal with the prostate cancer. Maybe it's just a little bit of hypertrophy of the prostate. But in any case, the urologist can then prescribe a medication to reduce the hypertrophy of the prostate. Maybe they can do an operation to eliminate the cancer, and then the patient can go back on their regular NOAC. So always try to treat the underlying cause. For severe life-threatening bleeding, now in the United States, there is a direct 10A antidote, which is called andexanet alpha, which can immediately neutralize the effects of the 10A inhibitors. But andexanet alpha is not yet available in all countries. So, for example, in Canada, we don't have access to it, and I'm not sure in Egypt if you have it. Maybe you do, maybe you don't.
No, not yet.
No, not yet. So, but that still should not panic you, because we do have a very good partial antidote for the 10A inhibitors, and that's called prothrombin complex concentrate, otherwise known as Beriplex or Octaplex. And even though we usually think about this as being an antidote for warfarin, as it turns out, in life-threatening bleeding cases, if you give PCC, you can actually reverse more than 80% of the effect of the NOAC, of the 10A inhibitor. So we have found in our experience that even in severe life-threatening bleeds, if we give PCC, we can often bring these patients under control.
Okay, perfect. In our daily practice, usually one patient comes to your clinic asking for you, doc, I'm under, for example, rivaroxaban 20 milligram, and I will have my tooth to be extracted in maybe next week. What's your advice to me? Should I keep it? Should I stop it a few days before? Or what's your advice for this patient?
Yeah, that's such a common question, Dr. Hossam. We all have patients who come and ask us this question. So I always tell the patient that if they're only getting 1 or 2 or 3 teeth extracted, that they don't need to stop the oral anticoagulation at all, because the amount of bleeding from a tooth extraction is very, very low. Now, even the dental association, so if you look at the recommendations of the Canadian Dental Association and the American Dental Association, they actually recommend in the dentistry recommendations that you do not have to stop the oral anticoagulation for a simple tooth extraction. So if the dentist is worried and will not do the tooth extraction because the patient is on oral anticoagulation, my advice to the patient is always find yourself a new dentist, because obviously this dentist is not up to date on his practice. But if they're going to get all of their teeth extracted, or if they're going to have major gum surgery or major oral maxillary surgery, then obviously you do need to stop the oral anticoagulation for 1 or 2 days before such surgery. But for an uncomplicated tooth extraction, you don't need to stop it.
And is this the same for the VKA or it's different?
I think it's the same for VKA. So I usually tell patients who are on VKA, I don't have that many patients who are still on VKA, but I think it's the same for VKA, that as long as their INR is not very, very high, like 4 or 3.5 or very, very high, as long as it's in their therapeutic range of 2 to 3, you can do an uncomplicated tooth extraction.
Okay, but what about major surgery? How many days you should stop it before it, and to regain it after surgery, after how many hours or how many days?
Yeah, so if we're talking about moderate or major surgery, so we're talking about, orthopedic surgery, or we're talking about general surgery or cardiac surgery or neurosurgery, these are big, big operations. And so usually we recommend stopping the NOAC for 2 to 3 days before the operation. And the decision for 2 days or 3 days is dependent on the risk of the patient and the risk of bleeding during the surgery. So if it's going to be, for example, a very bloody, general surgery where there's going to be a lot of blood loss, I might hold it for 3 days. If it's going to be relatively benign surgery, then maybe only 2 days. And then I always usually will restart the NOAC 24 hours after hemostasis when the surgery is finished. So I always ask the surgeon, how did the surgery go? Are you happy with your stitches? Are you happy with your bleeding? And if the surgeon says, yes, everything went well, everything is fine, I'm not worried about bleeding, then I'll start it in 24 hours.
Okay, perfect. Something happened usually because I have seen some patients who developed extensive anterior MI and developed LV thrombus at that time. I've seen one patient, his first presentation with stroke developed from the LV thrombus in spite of being kept under NOACs. I don't know your strategy. Should those patients till now kept on VKA or NOACs? And what's your strategy if recurrent stroke or stroke happened from the LV thrombus in spite of being kept under anticoagulation? Do you change it to another type or another group? What's your strategy for the LV thrombus management?
That's a very good question. So ultimately, we don't have a ton of evidence to guide us here, but there are some small studies that have been done. And I also look at it from a very practical point of view. So when the patient is in hospital after a large anterior MI, and we do an echo and we see there's a large mural thrombus, oftentimes what we'll do for those patients is we'll start them on low molecular weight heparin in order to bridge them to get the warfarin. Well, if we think about low molecular weight heparin like enoxaparin, for example, it is an injectable 10A inhibitor. So my argument would be, why should taking an oral 10A inhibitor be any different than taking an injectable 10A inhibitor, as long as you're getting adequate concentrations of drug in the blood? So I personally feel very comfortable starting my mural thrombus, LV thrombus patients on an oral 10A inhibitor, but I will usually pick one that is more potent. So for this, I usually recommend rivaroxaban 20 milligrams or edoxaban 60 milligrams, because my feeling is that apixaban 5 milligrams is not as potent as these other two NOACs. And there is some small studies, they're not large randomized studies, but small studies which have also demonstrated the safety of using the NOACs even in the case of ventricular thrombus.
Okay, but because this is, I've seen this patient in my practice that he developed stroke from the LV thrombus when he was under NOACs. Do you think you should change to VKA, or you should just keep it afterward, same NOAC, or change the NOAC?
Yeah, that's a good question. So which NOAC was it? Was it rivaroxaban or apixaban, or do you remember?
Apixaban 5 milligram BID.
Yeah, so that was my point, is that I think apixaban 5 BID is not as potent as, let's say, Xarelto 20. So I probably would have changed that patient to Xarelto 20.
Okay, great. If patient under NOAC can develop stroke from atrial fibrillation, how much time you need to restart the NOACs again after the development of a stroke?
Yeah, that's a great question, because obviously the concern is that if there is a big stroke and you restart the anticoagulation too quickly, you can get hemorrhagic transformation of the stroke and actually cause a bleed. And so the rule I always like to use is called the Hans-Diener rule. And the Hans-Diener rule was actually adopted by the ESC Atrial Fibrillation Guidelines Committee in 2016. And their recommendation is the 3-6-12 rule. So if the patient has a TIA and there's no evidence of infarction on the MRI, then you don't need to hold the oral anticoagulation at all. So it's 0 days hold. On the other hand, if the MRI demonstrates a small size stroke, then you need to hold the anticoagulation for 3 days. If it demonstrates a moderate size, then you need to hold the anticoagulation for 6 days. And if it demonstrates a very large stroke or multiple territory stroke, then you may need to hold the anticoagulation for 12 days. So the 3-6-12 Hans-Diener rule, this is the rule I use.
And what about intracranial hemorrhage?
Yeah, so intracranial hemorrhage is also a controversial area, but again, there are some guidelines in the 2016 ESC document. And generally speaking, it depends on whether the cause of the intracranial hemorrhage is considered reversible or non-reversible. So for example, if the patient falls and has a traumatic subdural hematoma, that's a reversible cause, because at least if the patient doesn't fall again, they will not get another subdural. That will heal. Similarly, if the patient has an aneurysmal bleed and has an intracerebral hemorrhage due to a ruptured aneurysm, and the neuroradiologist is able to go up and clip the aneurysm and stop the bleeding, then this is a reversible cause. So for these kinds of reversible causes of bleeds, we usually say that you hold the oral anticoagulation for 8 to 12 weeks. And then after 8 to 12 weeks, you repeat the imaging. And as long as everything is getting better, you can restart the oral anticoagulation. But if it's a non-reversible bleed, let's say the patient has an aneurysm that's leaking and they cannot clip it, or they cannot operate on it, or it was a spontaneous subarachnoid hemorrhage and there was no cause or reason for it, then in those cases, we may not be able to restart the oral anticoagulation, and we may have to consider something like left atrial appendage occlusion.
Okay, perfect. Thank you very much, Dr. Atul Verma, for really, really very nice information and everything. Any question from the audience? Okay, great. Thank you very much, Dr. Atul Verma. We are very happy to have you with us here, and I hope next time we do more lectures about you, to take you some of your experience about anticoagulation and arrhythmia. Thank you very much. Thank you.
It was a great pleasure, Dr. Osam. Thank you very much.
Thank you. Thank you. Bye-bye.
All right. Have a good day.
Thank you. Have a good day. Bye-bye. So now I would like to share my screen also to complete the topics for tonight regarding the presentation of NOACs. The second part of application of the NOACs on the venous thromboembolic disease and pulmonary embolism. And so I would like to share my presentation with you. How to protect our patient with pulmonary embolism. I'll just give an example. Our patient, Mr. Ayman, is 75 years old. He is obese patient, has pulmonary embolism after a recent long flight. He had prostatic cancer with creatinine clearance 42 ml per minute. So some kind of renal impairment, cancer, obesity, and attack of pulmonary embolism. As you see, patient with unprovoked and non-surgically provoked venous thromboembolism experience risk of recurrence. So what can we do to protect Mr. Ayman from the recurrent pulmonary embolism or venous thromboembolic disease? The risk of recurrence at 2 years is 20% in patient with unknown cause and 8% in patient with non-surgical cause. And this is the new classification in the International Society of Thrombosis and Homeostasis and Diversity guidelines regarding the instance of recurrence of VTE if unprovoked or persistent provoked or transient provoked reason for the development of venous thromboembolic disease. We need to focus in this presentation on two important points. Here's the frail patient, 75 years, and cancer at the same time. Those patients usually, as we were guessing all the time, that those patients have very high risk of recurrence and very high risk of major bleeding. So Mr. Ayman has an acute pulmonary embolism, prostatic cancer. His doctor prescribed him low molecular weight heparin with vitamin K antagonist. What is the traditional anticoagulant drawbacks? We have, apart from the NOACs, we have three types of anticoagulants, the traditional ones. The unfractionated heparin is parenterally administered. You should monitor the dose with the PTT all the time. Still, you have some risk of heparin-induced thrombocytopenia. The low molecular weight heparin, the famous one, Egypt enoxaparin, again, it's parenteral and needs some weight adjustment of the dosing, plus adjustment of the dosing in renal impairment. Oral vitamin K antagonist, narrow therapeutic window, and interaction with food and drugs and frequent monitoring required. And as you know, and we are seeing a lot of patients who even the very common, who are taking antibiotics, for example, you find jump of the INR. I've seen some patient INR of 9 or 12 just because they are taking, just finished the course of an antibiotic while under warfarin, and so close monitoring and narrow therapeutic window between the bleeding and thrombosis. And so this is a problem of the vitamin K antagonist. Difficult to keep it within therapeutic range, and we need frequent INR monitoring and dose adjustment, plus drug-drug interaction and food interaction, the vegetables, vitamin K, food, and slow onset and offset of action. So if you want to manage it for something urgent, you need some time, plus the increased risk of bleeding, as we'll see from some trials. So what are the properties of the ideal anticoagulant should have? It should be administered orally, convenient use both in and out of the hospital. The therapeutic window better to be wide, broad safety margin, wide range of effective doses, low risk of food and drug interactions, easy to use regardless of the concomitant medications and diet. Whatever the patient is taking from medication, whatever the behavior of diet, should not be affected. Predictability, safe and effective regulation of coagulation from the first dose and throughout therapy. It should not need monitoring. I mean that no need for routine laboratory monitoring, saves healthcare costs through fewer hospital and physician visits, and has less impact on patient time and cost as well. Fixed doses for the majority of patients, no need for dose adjustment. This is the criteria or the characters or the properties of an ideal anticoagulant. As this is a very famous slide for the NOACs and the way or the mode of action. As you see, just to highlight one point, I'll not go in depth. Factor 10A is affected by rivaroxaban, apixaban. However, dabigatran is working directly on the thrombin. And this is the difference in wave action of the three famous in Egypt NOACs, rivaroxaban, apixaban, and dabigatran. So it's another mode of action, another category. Maybe this is some of the reason why it's high bleeding risk, as Professor Atul Verma said, in the elderly patient or in the high dosage of 150 milligram of dabigatran in comparison to rivaroxaban and apixaban. Mr. Ayman, our patient, developed another pulmonary embolism after 1 year. Now his doctor switched him to rivaroxaban, started to think about it, was asking if injection should be given before rivaroxaban. we need to answer this question. If I will start for my patient rivaroxaban as an oral NOACs, should I start loading with low molecular weight heparin? The answer would be no. Rivaroxaban has rapid onset of action, reaching maximum anti-factor Xa activity at a similar point of time like enoxaparin. 2 to 4 hours from the starting of the dose, the same like enoxaparin, so no need to start with enoxaparin, just to start with rivaroxaban. How to switch from VKA to rivaroxaban? Mr. Ayman was under VKA, he developed pulmonary embolism under VKA, and we need to shift. Stop warfarin, measure the INR. Once it's reached below 2.5, which is actually, this is the therapeutic INR for us. You can give rivaroxaban immediately. I think in most of the patients, you will start immediately rivaroxaban because usually this is the average INR or the target INR for those patients. Just keep it a few days to go down from 3 to 2.5 and then start. The Einstein pulmonary embolism, this is the only study which studied NOACs to confirm early clot regression following acute pulmonary embolism. And this study, CT guided and VQ guided, just to study following the patient up for 21 days in 2 groups, rivaroxaban and low molecular weight heparin plus vitamin K antagonist, to see what about clot resolution in 3 weeks' time, monitored by CT or Q-scan. They found that 88% of those patients in both groups has resolution of the clot, whether partial resolution or complete resolution of the clot. 12% of the patient doesn't have any change in the clot, and no patient has worsening clot. So that means that with the rivaroxaban or VKA make good benefit for the patient in 3 weeks after the development of pulmonary embolism. So it's NOACs or rivaroxaban as effective as VKA in clot resolution in 3 weeks. When is the highest risk of VTE recurrence after the acute event? As you know, after development of the first event, the first 3 to 4 weeks carries the highest risk of recurrence, as you see here from this slide. After that, there is still some risk of recurrence, although low, but still there. So because of this, VTE remains a persistent threat. Because of this, because of the highest recurrence rate in the first 3 weeks, it's recommended to start with a high dose rivaroxaban, 15 milligram twice daily for the first 3 weeks, then shift to the 20 milligram once daily. And regarding the second part of the story, it remains a persistent threat. Because of it, for how long should we keep our patient on NOACs after the first 6 months of the standard therapy of VTE and pulmonary embolism? For how long? This will be answered in the next slides. That's why rivaroxaban dosage is covering the first 3 weeks with 15 milligram BID to protect patient against the VTE recurrence. So the regimen of VTE patient treatment of DVT or pulmonary embolism, 15 milligram twice daily with food. From day 22, transition to 20 milligram once daily with food. So the first 3 weeks, we are giving our patient 30 milligram, and afterward, we go down to 20 milligram once daily. An important thing, like Professor Verma highlighted also, regarding the renal function and dose adjustment. In order to summarize it and to avoid any confusion, let's go first to the critically diseased kidney, or the creatinine increase below 15 is not advised to give rivaroxaban. In the rest of creatinine clearance, either 50 to 80, 30 to 50, 15 to 30, no necessary to make any dose adjustment, but the only group of creatinine clearance from 15 to 30, just use it with caution. So there is no rule for the 10 milligram or 15 milligram low dose for the renal impairment, because I think there's some misunderstanding which was widely spread by the apixaban team, that dose adjustment is mandatory, and putting one of the three triad, as you see, or as we all know, about the body surface area, the age, and the creatinine clearance to go down to the 2.5 apixaban twice daily. Here's not the case. It's not necessary to make any dose adjustment for the rivaroxaban. However, just make some caution when you use it for the creatinine clearance from 15 to 30, and it's not recommended to use it if creatinine clearance below 15. Can rivaroxaban be used for fragile patient, age 75, creatinine clearance 42, like our patient, Mr. Ayman? Here's the slide shows that there is relative risk reduction of 73% for the frail patient, the elderly patient, in terms of major bleeding. So the effective treatment of frail VTE patient with significant reduction of major bleeding here. So there is some important point to highlight it and keep it in mind that in old patient, elderly patient, rivaroxaban much better than enoxaparin VKA. This is a good point when you choose the oral anticoagulant in frail patient, because there is significant reduction in major bleeding, so favoring rivaroxaban. Keep it in mind for the old patient. So what about the creatinine clearance for this patient? As you know, from the Einstein DVT and pulmonary embolism pooled analysis, the recurrence rate of VTE increase with deterioration of the kidney function in both groups, honestly, with the rivaroxaban group, with the low molecular weight heparin VKA group, may be numerically less than the rivaroxaban. However, deterioration of the kidney function carries a negative impact on the recurrence of VTE and pulmonary embolism. Although, as Professor Verma mentioned, that the patient of deteriorated kidney function benefited more from the rivaroxaban than patient with normal kidney function. What about major bleeding? Major bleeding here has a difference that favoring rivaroxaban in decreasing major bleeding in creatinine clearance less than 50 and from 50 to 80. The major bleeding favors usage of rivaroxaban in patients with impaired kidney function. As you see the difference between rivaroxaban and low molecular weight, favoring, of course, rivaroxaban. What about cancer? This is an important and new topic for the usage of rivaroxaban in cancer patient, as mentioned in the new guidelines. As you see, the recurrence of venous thromboembolism in patient with cancer is 2 to 9 times higher than in patient without cancer. Effective treatment in pulmonary embolism DVT patient with active cancer with significant reduction of major bleeding in cancer patient. The relative risk reduction 58% drop of major bleeding, favoring rivaroxaban over enoxaparin VKA. So another benefit, don't forget we've mentioned the frail old age patient, the renally impaired patient, the major bleeding favoring also rivaroxaban, old age also favoring rivaroxaban, cancer patient favoring rivaroxaban over enoxaparin and VKA. Here's a specific trial called the SELECT-D. It's prospective randomized multi-center pilot phase 3 study comparing rivaroxaban versus low molecular weight heparin, deltaparin, for the treatment of cancer-associated thrombosis, including 500 patients, half of them rivaroxaban 15 milligram BID as the usual standard protocol for 3 weeks, followed by 20 milligram once daily. The study population, active cancer, symptomatic DVT, with the performance score less than 2. That means performance score, this ECOG PS score less than 2, that this is the patient still can do his normal activity without complaint. He can behave a normal life. The second arm of the study, the dalteparin 200 units per kg once daily for the first month, followed by 150 per kg once daily, with some variable. Of course, stratification variables may occur during the enrollment or after the enrollment, the stage of the disease, stage of the cancer, of course, the chemotherapeutic agent, the platelet count, the baseline, or during the study after chemotherapy, injection may be dropped. So below 90, we should stop. This was the recommendation. We should stop the NOACs. And the type of VTE, it's either pulmonary embolism or VTE, including major veins or small caliber vein, and what is the risk of clotting by tumor type. So Ayman, our patient, needs protection against the VTE recurrence without an excessive risk of bleeding. The recurrence rate decreased with the rivaroxaban group by 57%. The VTE recurrence dropped in the selected patient with cancer-associated thrombosis, favoring the rivaroxaban. So the recurrence rate dropped significantly and without any difference in fatal bleeding or major bleeding. Again, the recurrence rate dropped. Here, a difference in the cancer patient, if we compare the rivaroxaban usage, as we mentioned before, the frail patient, the elderly, and the renally impaired, the recurrence rate dropped, the major bleeding dropped. Here, there's no difference in major bleeding between low molecular weight and the rivaroxaban, but the recurrence rate dropped by 57%. So the SELECT-D clinical trial, lower incidence of VTE with rivaroxaban versus dalteparin, 57%, same rate of major bleeding. And after this trial, there was a change in the guidelines by the International Society of Thrombosis and Homeostasis and the Burn Society Guidelines 2019 for the diagnosis and the management of acute pulmonary embolism developed in collaboration with the European Respiratory Society. Pulmonary embolism in cancer, edoxapan or rivaroxaban. The only NOACs which is studied in cancer patient, edoxapan or rivaroxaban. Edoxapan is not available in Egypt, so rivaroxaban should be considered as an alternative to low molecular weight heparin, with the exception of patients with GIT cancer. And class 2 level of evidence A. And here is the International Society of Thrombosis and Homeostasis guidance recommend rivaroxaban for the treatment of cancer-associated thrombosis. Specific NOACs, edoxapan, rivaroxaban as a first option in cancer patient with acute VTE with low risk of bleeding and no drug-drug interaction with current systematic therapy. Excluding from those patients the GIT cancer patient or the genitourinary cancer patient, nephrostomy patient, GI mucosal abnormality, duodenal ulcer, gastritis, esophagitis, those will be candidate for low molecular weight heparin. What if we would like to extend Ayman anticoagulation? This is still a debatable thing till now. Till now, for how long you should extend the usage of NOACs after the first 6 to 12 months from starting from the index pulmonary embolism or VTE. Just to remember our patient, 75 years obese, pulmonary embolism after flight, prostate cancer, creatinine kinase 42. No identifiable risk factor, persistent and minor, transient, reversible risk factor. So, should we extend beyond or not? This was studied in the Einstein extension trial and Einstein choice study design. Einstein studies studied the usage of rivaroxaban, the Einstein extension, after finishing the first 6 to 12 months of the index event of pulmonary embolism of VTE, including more than 1,000 patients. So after closing the first 6-12 months, they randomized the patient to two groups, half of them given rivaroxaban 20 milligrams once daily, and the other giving just a placebo, and observe it for another 1 month. Don't forget, after finishing the first 6 to 12 months from rivaroxaban from the standard regimen. This was the same for the Einstein choice, but with some difference that they randomized the patient after that to rivaroxaban 20 and include 3,000 patients. So the first arm rivaroxaban 20, second arm rivaroxaban 10, and the third arm aspirin 100 milligram, again for another 1 month. What we found in this? Of course, as you see here, the cumulative event rate favoring rivaroxaban with relative risk reduction of 82%, significant risk reduction with the rivaroxaban of continued use of rivaroxaban over placebo in the Einstein extension trial. The major bleeding was not significantly big. Out of 600 patients, there is 4 patients of major bleeding. In the Einstein choice, again, as we remember, 3,000 patients. So in those 3,000 patients, we, after the first 6 months, 3 arms were enrolled for rivaroxaban 20, rivaroxaban 10, and aspirin, and followed up for 30 days. Here, as you see, in terms of efficacy, rivaroxaban with its 2 doses was very effective in reducing the risk of VTE rates in comparison to aspirin. However, there is no difference in major bleeding between the 2 dosage of rivaroxaban and the aspirin. So, to summarize it, rivaroxaban with its 2 dosage decrease the cumulative index in terms of VTE recurrence rate without any increase of the major bleeding in comparison to aspirin after the first 6 to 12 months of the index event. This will take us to, should we continue those patients under rivaroxaban or NOACs after 1 year from the first event? This we will see. This is the new guidelines is decision making, will help us how can we extend the treatment of patients like Ayman. If this patient has a major transient provoked, major surgery, the risk of recurrence is less than 3%, so no need to extend. He has a major surgery, developed the event due to this major surgery, and accordingly, it's finished, and so no need to extend the NOACs. But we still have another classifications, the minor transient provoked, with minor reason, like long flights. Every one of us can take long flight. And if you develop pulmonary embolism or VTE in long flight, so your recurrence risk is intermediate from 3 to 8% to have it. The same, if unprovoked VTE or pulmonary without any identifiable risk factor, you still have intermediate risk of developing recurrence from 3 to 8%. And in this case, you should think of extension of the anticoagulation beyond the first year. Of course, with the persistent provoked, for example, active cancer, you should extend the usage of anticoagulation. You have the highest risk of recurrence. Depend on your decision. Should you extend it for him? No. This is a collective data from the 2 trials overlapping each other, the placebo, the aspirin, and the rivaroxaban with the 2 dosages from the Einstein extension and Einstein choice. Of course, as you see here, in the unprovoked, or minor transient provoked or minor persistent provoked the cumulative instance of recurrent VTE at 1 year, rivaroxaban, of course, over aspirin and the placebo. So I mentioned the high dose learning. So the standard regimen of rivaroxaban treatment dosing regimen, initial treatment 15 milligram BID, continued treatment 20 milligram once daily, and extended treatment 20 milligram once daily or 10 milligram once daily. In my point of view, I would think to say that 10 milligram once daily will be fine, because there is no big difference in the recurrence between the 20 milligram and 10 milligram in the extended treatment regimen without any negative impact on the major bleeding. If extended oral anticoagulation is decided after PE in patients without cancer, don't forget this point, without cancer, a reduced dose of rivaroxaban 10 milligram should be considered after 6 months. But in the presence of cancer, the high dose, I think, would be advised. In practice, how to convert from VKA to rivaroxaban? As we mentioned before, VKA therapy should be stopped. INR measurement has to continue. Rivaroxaban should be initiated when INR is below 2.5 in case of DVT and pulmonary embolism. Converting between the anticoagulants, rivaroxaban, heparin, low molecular weight, and vice versa. Patient who receive continuously administered parenteral, such as IV heparin, you should start Xarelto immediately. What about if he is under enoxaparin with fixed dosage every 12 hours? As you know, you should start at the second dose from 0 to 2 hours before the time of the next scheduled dose. I mean, you give the enoxaparin dose in the morning, you start after 12 hours with Xarelto. Patient who receives Xarelto, when you are in need to convert to parenteral, just start the parenteral administration instead of next Xarelto dose at the planned time. Bleeding management protocols are very important, as mentioned by Professor Verma. How should you manage your patient with bleeding if he developed a bleeding under rivaroxaban? If it is minor bleeding, consider the delaying or discontinuing next dose and see what's going on. Just hold some dosage and see. If it is major bleeding, the major bleeding, symptomatic and local measures, mechanical compression, surgical intervention, homeostasis, volume management. If it is major bleeding, and of course, hold the dosage till you see. But if it is life-threatening bleeding, as mentioned by Professor Verma, the antidotes now available, maybe not in Egypt, Dexanet alpha, you can use it, but still, as also mentioned Verma, achieve 80% reversibility by considering the prothrombin complex concentrate all the recombinants. So this is the life plus the standard measures for stopping bleeding, whether intervention, stopping the dosage, reversing the dose in major bleeding. So no need to reverse the dose in life in major bleeding or minor bleeding, only in life-threatening bleeding. What if the patient will have surgery and under NOACs? If it is elective surgery, you can stop it for 24, 48 hours. And as mentioned by Professor Verma, regarding the minor procedures like dental extraction, cataract operation, endoscopy without biopsy, you don't need to stop. You can go for it. But if you have elective surgery, open surgery, you can stop it 1 to 2 days before surgery. If it is emergency surgery, you should calculate the risk-benefit ratio for the urgency of it. If patient without bleeding, don't use PCC. But if the patient with severe bleeding, consider using PCC and then go for surgery. So if the patient doesn't have bleeding, just go for surgery without using PCC, being emergency. But if he has bleeding, give PCC or the antidote if available and then go for surgery. When to restart NOACs? When adequate hemostasis is achieved, usually 8 hours after surgery. This is the regimen of our VTE patient. Treatment of DVT in pulmonary venous, 15 mg twice daily with food, and for 3 weeks then start with 20 mg once daily with food. Again, there is no dose adjustment. For renal function, don't use it below 15, use it with caution from 15 to 30. In conclusion, patients with pulmonary embolism are offered more protection with rivaroxaban than low molecular weight heparin VKA on the level of VTE recurrence and bleeding. Patient compliance is better with rivaroxaban than injection. Rivaroxaban is now indicated as first option by International Society of Thrombosis and Homeostasis guidelines as an alternative to low molecular weight heparin for patient with VTE and the cancer, unless the patient has GI cancer. So now there is more convenient anticoagulation for patient with VTE and cancer. Thank you. Okay, I hope you get some benefit from the presentation. I would like to thank Fire Company and Professor Verma and all the audience. If any question, just to summarize again, this presentation reflected the benefit of rivaroxaban in cancer patient, in frail elderly patient, and in renally impaired patient. If you have any question, you are welcome to have it. I hope you enjoyed the lecture and get benefit from it. Thank you.